Okay, good morning. Hi, I hope everyone can hear me. If not, let Debbie know. I'm Dr. Colon, and I'm one of the maternal-fetal medicine doctors here at the Department of OB-Gyn. And thank you so much for the invitation to speak with you all today on prenatal care pearls. So our objectives for this morning are to describe the components of prenatal tests and procedures and when they are done and why they are done. We're also going to discuss the basics of diabetes in pregnancy, and we're also going to discuss and identify the differences in hypertensive disorders in pregnancy. So the objective of prenatal care is to assure that every wanted pregnancy culminates in the delivery of a healthy baby without impairing the health of the mother. And most of us that have a passion for obstetrics, this is one of the reasons that at least I did go into this specialty, because it allows you to take care of a woman during a very special time in their life. And usually we have a good outcome. And again, this is all relative, right? In my specialty, in particular in MFM, a good outcome might be a delivery at 28 weeks in a patient that has a very complicated medical history. So our job is to try to get every mother a healthy baby, considering all their circumstances, and manage their medical as well as their obstetrical complications. So in prenatal care, we order a lot of different testing and different procedures throughout the pregnancy, but particularly in the first trimester, during their, usually in the first trimester for most patients, during their first prenatal visit, we are gonna get an array of blood testing. And I always like to go through these because there is a reason why we order each and every one of these tests. And usually when we're in person, I like to go around the room and just ask everyone why they think we order this particular test. But given the circumstances of being on Zoom, I'm just going to go through them. So the blood type and group, as well as an antibody screen, is a very important test because we want to see if this patient has any antibodies that may give her a risk for fetal anemia, in the case of the most common one, which is Rh isoimmunization. But there are others like KEL and Duffy and other antibodies that may also cause significant problems in a pregnancy. The other reason we want to screen is the patient may have unusual antibodies that may need us to work on getting the appropriate type of blood in case of needing a blood transfusion. So for those reasons, it's important that we test every patient for their blood type and antibody screen. As well, we get a CBC, and you can imagine how many things we can screen for with our CBC, including the presence of anemia, if the patient has a platelet disorder, like for example, if you obtain a low platelet count early in the pregnancy, it may point you to working for ITP or other platelet disorders as well. Very rare, but you could pick an abnormality in a white blood cell count that may need workup for a cancer, as well as the indices. As you know, the one that we look very carefully for is the MCV, because we can detect different types of anemia. We also get a urinalysis and a urine culture, As we know, in pregnancy, there's an increased risk for urine infections and asymptomatic bacteriuria to ascend and create a problem with kidney infections. So in the non-pregnant patient, asymptomatic bacteriuria is usually not routinely treated, but in a pregnant patient with asymptomatic bacteriuria, we treat them because it could result in a kidney infection and other things down the road, like preterm labor and delivery. Also, your asymptomatic bacteriuria, if it's particularly with GBS, it's very important to treat, as we know the associations of GBS with other fetal problems. The rubella antibody titer we obtain in the beginning of the pregnancy is not because we can do something about it necessarily during the current pregnancy, as we cannot vaccinate a patient with MMR as it's a live vaccine, but it's important because we can then vaccinate the patient after delivery to prevent any impact on future pregnancies. The HIV test, very important test, because we can do so much for a patient that has undiagnosed HIV during pregnancy, and we can also do so much to prevent transmission to her unborn baby. So HIV test used to be a test where patients needed to specifically give consent for to get tested. Now it's more of an opt-out. So that guideline was changed, so we have to inform patients that HIV testing is part of their prenatal screen, but they don't need to sign a consent, which used to be the case several years ago. And as you know, treatment of HIV during pregnancy can decrease the risk for transmission to the fetus and to the baby to less than 1% with an undetectable viral load. So this is an area where we can make a dramatic difference during a woman's pregnancy. We also get a syphilis screen, and particularly in this county, we repeat our syphilis screen, as you know, in the 3rd trimester, due to the incidence of congenital syphilis in our population. So very important screen and treatment during pregnancy. If a patient is found to be positive for syphilis, the treatment is penicillin, and it's very important to institute this treatment during the pregnancy. And if the patient is penicillin allergic, she needs to be admitted to the hospital for desensitization and treatment with penicillin. The hepatitis B virus screen as well, another important test that we get. We don't usually treat the mom for this during the pregnancy, but if she's found to be Hep B positive, the treatment of the baby is different at birth than a baby that's born to a mom that does not have hepatitis B. So this is very important because they would need IVIG at birth, besides the vaccination that's routinely given to all babies. Cervical cytology, it's pretty standard if a patient does not have a up-to-date PAP to obtain one during pregnancy, because we have a patient that's going to be under our care for several months. So if we can detect any problems with any abnormality of their pap smear, a colposcopy can be performed. Usually biopsies are not performed during pregnancy unless it's a very high suspicion for a malignancy. Otherwise, they're followed up postpartum, and that's when, if needed, they may get their biopsy. And a hemoglobin A1C has become part of routine first prenatal visit labs here, particularly in our institution, to try and detect any presence of pre-gestational diabetes so that we can, again, institute maternal treatment for better and improved pregnancy outcomes. In terms of other testing and procedures that we can do for screening for chromosomal abnormalities, between the 10 to 14 week range in the first trimester, we have first trimester screening, which consists of both a blood test and an ultrasound to measure nuchal translucency. So this screening, the AFP we call it AFP1, but it doesn't include AFP. It's the first trimester screening, it's actually HCG and PAP-A. And the nuchal translucency is the measurement of the skin of the neck of the fetus during a detailed first trimester ultrasound. There's also the option of doing maternal cell-free DNA. And there's also the option for those patients that either have a risk for a genetic, for a chromosomal anomaly or a prior history. During the first trimester, the test that's available, it's a chorionic villus sampling, and this is actually tissue sampling from the placenta. This is a diagnostic test versus the prior two options are screening tests. Then in the second trimester, between 16 to 18 or 20 weeks, we perform an ultrasound to look for any fetal anomalies, look at any placental disorders or any amniotic fluid disorders. And during this time period is when we offer maternal serum screening AFP as well, that screens for Down syndrome, trisomy 18, and open neural tube defects. As well, those patients that are either of advanced maternal age or have a prior history of a chromosomal anomaly or have a fetal anomaly that needs diagnosis, they are offered then amniocentesis, which again is a diagnostic test versus ultrasound and maternal serum screening are screening tests. Now, talking a little bit about the second trimester screening in a little more detail, the three components of the screening portion measure AFP, HCG, and UE3. Again, this is going to provide an estimated risk, like I mentioned previously. It is not a diagnostic test. And this is very important to counsel the patients when they get this test, because when we see them for their ultrasound and counseling at the MFM clinic, a lot of them are under the impression that their baby has this problem. So it's important to remember that it is not a diagnostic test. So it screens for neural tube defects, and this would present in the screening test as a very elevated AFP or a very high MOM. It can also point to an abdominal wall defect, because again, it's also a defect where contents are exposed, so AFP will also be elevated. And then the other thing that screens for are T21 and T18. So when talking about Down syndrome, which is pretty much what people refer to when they do their AFP screen, it's like, oh, it's my Down syndrome screening, even though we know it screens for other things. It's important to remember that the only way to make a definitive diagnosis is by either CVS or amniocentesis. And this is something that shows how much AFP has revolutionized the detection rate. When at first we would offer amnios only to women that were of advanced maternal age, which is considered to be greater than 35 years of age. But that would only pick up 20% of the fetal Down syndrome population, because the majority of Down syndrome actually does not occur in advanced maternal age moms, but in younger moms because they represent the majority of pregnant women. So since we were able to incorporate maternal serum screening, then we have been able to identify an additional 40% of babies with Down syndrome. And if we look at the sonographic criteria as alone, we could identify up to 70% of fetuses with Down syndrome. This is just sonogram alone. Because again, remember that a lot of babies that have Down syndrome are completely normal anatomically. So their ultrasound is going to be completely normal. Moving along during the pregnancy, when we reach about 26 weeks, 24, 26 to 28 weeks, we do our diabetes screening. And this is with the 2-hour GTT here in our institution. We do a repeat CBC, right? Looking for any evidence of iron deficiency anemia, which is pretty common in pregnancy, but also important to look at all the other parameters in your CBC. And those patients that are Rh negative have a repeat antibody test and prophylactic administration of RhoGAM to prevent isoimmunization. At 36 weeks or so, we do our GBS rectovaginal culture. And it's important to remember that up to 30% of women are going to be GBS positive during their pregnancy. So sometimes patients are concerned when we tell them that they are GBS positive. They think they're infected, or they think, oh my gosh, is this so bad? And so I always counsel my patients that this is just a routine screening test, and that it doesn't mean that they have an infection, because as you know, GBS it does not represent an infection, a vaginal infection, but it's very important because it helps to prevent transmission to the baby, right? So as with most of the things we do in prenatal care, we're testing the mom because we have interventions that can provide a better outcome for the baby. So I always counsel my patients, we want to know about this because it's something we can do to prevent an infection in your baby. So it's not anything wrong with you or any infection with you. So the treatment is penicillin in labor, right? We don't need to treat the mom for a positive GBS culture obtained, routinely in clinic. It's only if they have GBS bacteriuria, but not from the routine rectovaginal swab. And those patients that are penicillin allergic, we send the culture with that special mark, right? Like we let the lab know so that then they can test for clindamycin resistance or not, so that we can use other agents in labor. If you don't know, like let's say the patient arrives, you don't have a GBS culture, or she needs treatment because she's preterm and you don't have sensitivities and they're penicillin allergic. The options include Ansev, Clinda, or vancomycin will be first choice until you have the result. Diabetes in pregnancy is something we see pretty commonly here in our institution, and we have a specific diabetes in pregnancy clinic to manage these patients. But I think it's very important for everyone to have a baseline knowledge of how to manage diabetes and what are the important things that we all should know. And one of the basic differences are those patients that have pregestational diabetes versus those patients that have gestational diabetes. So those that have pregestational diabetes are patients that need very intensive prenatal care. They undergo very good management between the MFM and our nurse practitioners that help us manage these patients in our program. And these are patients that we see pretty much weekly during their pregnancy. So these patients get a hemoglobin A1C, pre-conception and also later in the first trimester, as well as pretty much monthly during their pregnancy to assess their level of control. In terms of other organs that may be affected by diabetes, our patients get an ophthalmologic examination, as well as blood work to test for any other organs that may be affected by their diabetes, including their kidneys. So these patients also get UPC and microalbuminuria. A lot of these patients may have baseline microalbuminuria, which as you improve their glucose control, their microalbuminuria actually may resolve during the pregnancy. The other thing, they may have baseline fatty liver of pregnancy, which baseline fatty liver from the diabetes in pregnancy that we pretty much pick up during the pregnancy with increased LFTs. And you also see that these patients, as they improve their glucose control, also have improvement in their LFTs and their baseline fatty liver. So this is a population that's very close and dear to my heart because we can do so much to improve maternal health during the pregnancy, and this can sometimes continue after they're not pregnant if it's a very highly motivated mom and they get really into controlling their sugars and they see the benefit of controlling their sugars, both for the baby and for themselves. In terms of the baby, we do a fetal echo. So besides the normal anatomy ultrasound, we also do a fetal echo at 22 weeks because moms with diabetes have an increased risk for cardiac anomalies. And this is particularly even more significant in those patients that have a hemoglobin A1C greater than 9. Then during the pregnancy, we do serial ultrasounds for growth, as well as NSC and amniotic fluid checks. Gestational diabetes is diagnosed a little later in pregnancy in the routine 2-hour GTT screening between 26 and 28 weeks. Like I mentioned previously, in our institution, we do a 2-hour GTT. We had the pleasure of having Dr. Jack Kitzmiller be a member of our MFM group for many years, and he was a member of he participated in the largest study that recommended the 2-hour GTT as a screening versus the 1-hour glucola. So that's why we do that here in our institution. And as you know, you need only one abnormal value in this test to give you a diagnosis of gestational diabetes. So those patients usually get started, they usually are pretty much A1 GDMs, meaning they're diet controlled. So they get started on a special diet and a special exercise program. And a portion of them that their sugars are still elevated, even with these 2 treatment options, then they may need to be started either on metformin or insulin, or glyburide, it's another option. And those are our A2 gestational diabetics. Hypertensive disorders of pregnancy are also a very common complication that we are all going to see. There are different types of hypertensives in pregnancy. So those patients that have hypertension prior to the pregnancy, or diagnosed before the 20th week of gestation, those are chronic hypertensive patients. Those patients that develop hypertension during the pregnancy are going to fall either into preeclampsia, eclampsia category, or gestational hypertensives. So preeclampsia requires a blood pressure of greater than 140 systolic or greater than 90 diastolic, at least 4 hours apart, as well as proteinuria, which can be diagnosed with a UPC of greater than 0.3 or greater than 300 milligrams in 24 hours. It used to be standard to obtain a 24-hour urine collection in the past, but nowadays we have the great advantage that this can be done with the UPC, and we can obtain a pretty accurate diagnosis, but also a faster diagnosis so that we know how to manage the patient. Now, as we know per the most recent ACOG bulletin, you don't need to have necessarily the proteinuria to meet the criteria for preeclampsia. So you can have other things that make you preeclamptic, which include any abnormalities in your labs like thrombocytopenia or LFTs that are greater than 2 times normal, or if you have any symptoms of preeclampsia like headache, vision changes, or upper quadrant pain that are unresolved by pain medications. These patients also meet criteria for preeclampsia even if they don't have the proteinuria at presentation. You can also have patients that have chronic hypertension baseline and then develop superimposed preeclampsia upon their chronic hypertension if they developed uncontrolled blood pressures with rising proteinuria or the other lab abnormalities or symptoms. If a patient just has pure hypertension alone with no other abnormalities, no other symptoms, and it develops after the 20th week of pregnancy, then these are gestational hypertensives, but it's important to remember that these patients have a very increased risk of becoming preeclamptics. So we have to manage them as well very carefully and monitor them very closely. So for mild preeclampsia, talking about the treatment now, if a patient is at term, we would proceed to deliver the patient. So preeclampsia, even if mild, is an indication for delivery at 37 weeks and beyond. Now, if the patient is premature, then these patients should be hospitalized so that we can determine their baseline risk to progress to severe preeclampsia. So these patients get labs, we monitor their I's and O's, and we administer betamethasone for fetal long maturity. In general, I like to observe these patients that are premature with preeclampsia at least a few days to determine if they are going to be stable or not, to be a candidate for outpatient management or not. And if a patient with mild preeclampsia develops any symptoms or signs of severe preeclampsia, then you would proceed with delivery as well. But we will talk a little bit about this at the preemies in a different slide. Then magnesium sulfate is indicated for seizure prophylaxis in labor if your patient develops severe preeclampsia. So the laboratory evaluation in these patients is pretty extensive. We do a CBC to look at their hematocrit, and usually these patients have hemo concentration. We also look very carefully at the platelet count because a subset of these patients are going to have thrombocytopenia, and depending on the degree of thrombocytopenia, they may qualify for HEP syndrome. We also look at their serum creatinine to determine their kidney function and the liver function test to also see if they have elevation that may also indicate HELLP syndrome. We also look at their coagulation profile, and it's very important to remember that fibrinogen in pregnancy of less than 200 is abnormal. So we do want to keep that fibrinogen high enough, especially if we need to perform surgery on these patients. And then again, the urine protein, which we nowadays do a UPC. There might be some rare indications to do a 24-hour urine collection, but most likely it's just we do a UPC. Now, those patients for severe preeclampsia, their blood pressure criteria include a systolic blood pressure of greater than 160 or a diastolic of greater than 110. It's important to note that you do not need to wait 4 hours to diagnose severe preeclampsia by blood pressures, because we need to treat the blood pressures within 20 minutes according to the ACOG bulletin, and the sooner the better. So if you have a patient that has severe blood pressures, we need to treat the severe blood pressures immediately. It used to be that patients needed to meet a proteinuria of greater than 5 grams in 24 hours, but this is no longer part of the diagnostic criteria. But I like to keep it here in my slide because it is a marker of worse disease, right? If you have a patient that's spilling 5 grams, 10 grams of protein, even though the protein alone is not going to make them severe preeclamptics, it is a patient that in my eyes is sicker or has the risk of getting worse than a patient that does not have a lot of proteinuria. Then the symptoms that make it severe preeclampsia are headache, visual changes, and right upper quadrant pain, or the laboratory values, which include thrombocytopenia, elevated liver enzymes, or a rising creatinine. A fetus that has IUGR or oligohydramnios as well used to be part of the diagnostic criteria. It is no longer a part of the diagnostic criteria, but again, we cannot forget that we need to evaluate the fetus in the workup of preeclampsia, and those fetuses that are already displaying IUGR or oligohydramnios do signal a patient that has worse disease. So it's a patient that makes me more concerned because we are already seeing end organ damage in form of damage or compromise of the fetus. So severe preeclampsia is an indication for delivery at any gestational age because of maternal health. Now, some patients may be candidates for expectant management if they are preterm, because there are advantages to trying to obtain an improved gestational age for the baby. And this is all based on the original study by Dr. Brahasibai, which has now, there's many more evidence now for this approach, but the original trial was looking at comparing patients that were premature with severe preeclampsia with immediate delivery versus those that could meet criteria for expectant management in the hospital. And it was shown that those patients managed very carefully in the hospital with serial labs and daily testing were able to gain a 2-week latency period. So their babies had the advantage of an additional 2 weeks, which represented improved outcomes for babies and less time in the NICU. Now, there are some criteria that if a patient meets, she is not a candidate for expectant management. And those include once you are maxed out on 2 hypertensive agents, or if you develop HELP syndrome, or if you develop unremitting symptoms of preeclampsia or seizures, you are no longer a candidate for expectant management, and delivery should be expedited. The patients with severe preeclampsia need to be treated with magnesium sulfate for seizure prophylaxis during labor, as well as postpartum for 24 hours. Eclampsia is when a woman with preeclampsia develops seizures, and delivery is indicated regardless of gestational age. And HELP syndrome, which we have as well talked during this presentation, it's when a patient has evidence of hemolysis or elevated liver enzymes 2 times more than normal, or low platelets less than 100,000. When a patient develops HELP syndrome, delivery is also indicated. Now, if the gestational age is of extreme prematurity, especially 24 to 30 weeks, but even up to 34 weeks, delivery may be temporized while we administer betamethasone. Again, if the mom and the baby are in an otherwise stable condition. Now, if mom deteriorates during this process of trying to get betamethasone complete, or the baby develops non-reassuring fetal status, then delivery is indicated. Thank you so much for your attention this morning, and I'm available for questions. If anyone has any questions, let me put here, oh gee. Here we go, okay.